palatine tonsils. When we say the tonsil, it means the mainly we are talking about the palatine tonsil. The tonsils that are located on the oropharyngeal airway, they form a ring known as Waldear's ring, and there are four tonsils: palatine tonsil on the both sides, lingual tonsil, and pharyngeal tonsil. So this is the situated on the posterior nasopharynx. This is pharyngeal tonsil. This is the lingual tonsil, and these are the palatine tonsils. And this is the this picture indicates the tubal tonsils. So this is the circle or the ring that is known as Waldear's ring. Now, when we talk about palatine tonsil has some crypts, and it is covered with the respiratory epithelium, and it is a lymphoid tissue, mucosa associated lymphoid tissue, which contains T cells and B cells and macrophages, and they protect from the bacterial infection. And the sensory nerve supply of the palatine tonsil are mainly glossopharyngeal nerve, the ninth cranial nerve, and the lesser palatine nerve, which is a branch of maxillary nerve, which is branch of trigeminal nerve, the fifth cranial nerve. The palatine tonsil blood supply is from the tonsillar branch of the facial artery, which is a branch of external carotid artery, and the venous supply is the venous drainage from the pharyngeal plexus of which drains into the internal jugular vein. And there is one more supply, that is external palatine vein from the soft palate. The bleeding is mainly post-operative bleeding is mainly concerned with the external palatine vein. This picture is showing the Waldear's ring. Here, this is the palatine tonsil, this is the pharyngeal tonsil, and these are the lingual tonsils. This image showing the cross section of palatine tonsil. These are the crypts. This is the crypta magna. This is the tonsillar capsule, and this is peritonsillar space. And there is one fascia, parapharyngeal fascia, and this is the buccopharyngeal fascia, and this is the constrictor muscle. And behind this buccopharyngeal fascia, you can see there is four cranial nerves: 9th, 10th, 11th, and 12th, and internal jugular vein, internal carotid artery, and external carotid artery between the buccopharyngeal fossa and the mandible. And at lower end of the lower end of the tonsil, palatine tonsil, we can see there are some there is artery, lingual artery, which is shown in the next picture. This picture is showing the lingual artery at the lower end of the palatine tonsil, and parapharyngeal fossa and buccopharyngeal fossa, and this is the branch of external carotid artery. In nutshell, the lymphoid tissue in the tonsillar fossa is palatine tonsil. Anteriorly, it has a palatoglossal arch, and posteriorly, it has a palatopharyngeal arch. Superiorly, soft palate is located. Inferiorly, the tongue is located. Medially, the palatine tonsil contains mucosa and 20 tonsillar crypts and intratonsillar cleft, and the bed is formed by the submucosa capsule, superior constrictor facial artery and its branches, lymphatic drainage to the cervical and jugulogastric lymph nodes, and veins plexus in the capsule to pharyngeal venous plexus, also external palatine from the soft palate. Nerve supply is tonsillar branch of the glossopharyngeal nerve, ninth cranial nerve, hence the referred vein goes to the middle ear. Also the lesser palatine maxillary branch via pterygopalatine ganglion. Development is from the second pharyngeal pouch, endoderm gives mucosa and crypts, and surrounding mesenchymal gives lymphoid tissue. Now blood supply, when we are looking down at right tonsil, we can see that blood supply is from the external carotid artery, from the facial artery and lingual artery. So ascending palatine and tonsillar branch of facial artery. This is the superior constrictor muscle. So tonsil is a lymphoid tissue which contains the lymphocytes and immunoglobulins. Formation happens there. Absolute indication of tonsillectomy are when the tonsil is of very large size, it causes dysphagia, choking, breathing difficulty, stridor, obstructive sleep apnea, and severe tonsillitis causing seizures, resistant tonsillitis due to peritonsillar abscess, resistant to antibiotics, for biopsy needed for confirmation of neoplastic etiology. Relative indications are sore throat due to tonsillitis, cause neoplastic suspicion, needed biopsy, and more than 5 episodes per year for 2 years, more than 7 episodes of acute tonsillitis in the 1 year, and more than 3 episodes per year for 3 years. Chronic tonsillitis symptoms persisting for more than 1 year. Chronic tonsillitis causing bad breath, bitter taste, streptococcal carrier state. Contraindication are acute infection, bleeding diathesis, anemia, significant anesthetic risk. Preoperative checkup, we focus on history related to birth, developmental milestones, vaccinations. We will examine the oral airway. We'll focus on the airway difficulty, general and systemic examination, especially focus on obstructive sleep apnea features suggestive of chronic hypoxemia, polycythemia, features suggestive of snoring, apneic episodes, and in ECG changes may be related with the right ventricular hypertrophy. During preoperative period, analgesics are given. We can give paracetamol 20 mg per kg orally or ibuprofen 5 mg per kg orally. For induction, inhalational agent is preferred to the sevoflurane. When there is history of apnea or obstructive sleep apnea, we usually avoid IV induction agent and muscle relaxant. We usually go ahead with the inhalational agent like sevoflurane. Airway secured with the ET tube, either through the flexometallic ET tube or RAE tube, north pole or south pole, or laryngeal muscle airway, laryngeal airway. Inhalational induction challenging due to adenoid obstruction of the airway. IV agent propofol 1.5 to 2.5 mg per kg or thiopentone 2 to 7 mg per kg. Airway insertion under deep anesthesia is preferred, or using the short-acting muscle relaxant like succinylcholine or mivacuronium. Spontaneous or controlled ventilation is preferred. Most children can be intubated or using the suxamethonium 0.5 to 2.0 mg per kg or short-acting NDMAR mivac non-depolarizing muscle relaxant mivacurium 0.1 to 0.2 mg per kg, and then allow breath spontaneous via ET tube. Positioning in supine position, roach position, neck extended, mouth clamp, Boyle Davis gag. ET tube should be secured in the midline. Surgical technique, cold steel dissection with the tie or PAX hemostasis, cold steel dissection with diathermy hemostasis, hot dissection by the mono or bipolar diathermy 400 degrees Celsius centigrade, 600 degrees centigrade, coagulation using lower temperature electrocautery 60 to 70 degree. Incidence of post-operative complication is linked to the surgical technique used. Cold steel dissection has lowest risk, and diathermy increases risk of bleeding and pain. Intraoperative analgesia, morphine 0.1 mg per kg or fentanyl 1 to 5 microgram per kg. An antiemetic should be considered. Injection ondansetron 0.1 mg per kg, injection dexamethasone 0.1 to 1 mg per kg. Post-surgery emergence, careful suction of oropharynx under direct vision ensures a dry airway at the end of surgery. Adequate spontaneous respiration is essential before extubation. Extubate in left lateral position. Position with the slight head down tilt and awake extubation is preferred. Post-op management, oxygen plus analgesia and observe for post-operative bleeding. We can give paracetamol or ibuprofen, routine monitoring and keep on the recovery position. Recovery position is a left lateral position. Complication, post-operative nausea, vomiting, pain, bleeding and aspiration. Post-tonsillectomy bleed. It could be serious. It can be immediate or delayed. Indicators are persistent swallowing action. If re-intubation is required, then it must be considered. That patient might be a full stomach of the blood due to aspiration of blood. There is aspiration risk, edema of the airway because of previous intubation, and the blood in the airway. IV fluid should be needed to rehydrate in case of hypovolemia and hypovolemic shock. Consciousness, GCS has to be assessed, and capillary refill time, pulse rate, urine output should be checked. RSI is done. Rapid sequence intubation and Rice tube needed to empty the stomach. We plan to extubate in awake condition when the protective airway reflexes are present. Head down tilt. Keep in recovery position for extended period to ensure safety from the bleeding. Important points. The single dose dexamethasone 0.15 to 1 mg per kg is associated with reduced post-operative nausea, vomiting. NSAIDs do not increase bleed, so they can be beneficial. Important structure at the lower pole of the tonsils are lingual artery, internal carotid artery, and glossopharyngeal nerve. Triad of hyponasality, snoring, and mouth breathing. They indicate the enlarged adenoids. Adenoid faces, large face, depressed nose, open mouth. Optimization prior to surgery, dehydration, and infection. Goal of anesthesia. We have to maintain deep general anesthesia to prevent reflex hypertension and increase in heart rate. Muscle relaxant to place the mouth gag. Rapid recovery and return of protective airway reflexes is desired. Primary bleeding can occur less than 24 hours. Secondary bleeding occurs more than 24 hours, mainly 5 to 28 days. Tonsillar bleed occurs in 6 to 8 hours. Observe for 10 hours in post-operative. Any blood coming from the mouth, frequent swallowing action, coffee ground vomitus, tachycardia, hypertension, these are the indicative of bleeding. Minor bleed can be treated with a gargling, ice pack, ice water packing. If bleed persists and it is and patient is uncooperative, then we might have to re-explore. Degree of loss, massive, sometimes get unnoticed in child. A child may go into hypovolemic shock. They might be having full stomach because of ingestion of the blood, and risk of hypothermia is also there. So point from the Morgan book. The tonsillitis is upper airway obstruction. It can cause obstructive sleep apnea. Patients are obligate mouth breathers. The ECG might suggest RVH and pulmonary arterial hypertension. Postpone surgery, infection or clotting abnormalities. Postpone surgery if there are infection or clotting abnormality. If there is history of airway obstruction or apnea, need induction with inhalational agent preferred without the muscle relaxant until the ability to ventilate with the positive pressure is established. Deep extubation is preferred. Deep extubation leads to decreased laryngospasm and decreased bleed, but awake extubation leads to decreased aspiration. Awake extubation is preferred. Prior to extubation, gastric suctioning is done. Post-op bleeding indicates the restlessness, tachycardia, decreased BP, and pallor. Tonsillar hypertrophy is graded from 0 to 4. Induction is usually done with sevoflurane plus oxygen plus and minus nitrous oxide. From the Barras book, long-standing hypoxemia or hypercarbia leads to increased airway resistance, which in turn leads to pulmonary vasoconstriction, which leads to pulmonary arterial hypertension, right-sided heart failure, and carpulmonale. Physical examination focus on audible respiration, mouth breathing, nasal speech, chest retraction, enlarged face, retrognathic mandible, and high arch palate. Obstructive sleep apnea can be detected by the polysomnography or sleep study. A stop bank questionnaire is also followed in adults. Snoring history, daytime sleepiness history, tiredness, observed of apnea, and hypertension. STBUR is for pediatric population, snoring, trouble breathing, unrefreshed after sleep. Goal are unconscious. This child should be unconscious to provide a clear field of view for the surgeon. Proper IV access and volume expansion awake emergence. Pre-medication only anti-sialagogue is preferred to reduce the secretions. Induction from the volatile agent with oxygen with nitrous oxide by the mask. Intubation. Deep anesthetic plane plus short-acting neuromuscular agent. The paracetamol for pain and fentanyl for pain. Dexmedetomidine 0.5 to 1 microgram per kg infused during the procedure may attenuate the emergence delirium. In OSA, opioid dose is reduced 50%. And nasal packing is required and cuff tube is preferred. Thank you.